Good evening. I'm Sona Jain, and I'd like to welcome you to the Hand in Hand webinar series of the American Association for Hand Surgery. I apologize, my video is not working, a little technical difficulties, but this webinar is in collaboration with the American Society for Peripheral Nerve, and I'd like to introduce our Hand in Hand webinar series lead, Dr. Suhail Mitani from Duke University. Suhail?
Thanks, Sonu, and I'd like to thank everybody for making it this evening or afternoon, depending on where you're at. Excited to kick off the Hand in Hand webinar series with this collaboration between the American Association for Hand Surgery and the American Society for Peripheral Nerve. And as you can see, we have an exciting program driven by Dr. Neil Lee from Duke, going over from paralysis to power, nerve, tendon, and rehab innovations to shoulder restoration across diverse pathologies. So, Neil, take it away.
Thanks, Suhail. Well, again, thank you everyone for joining. We put together this incredible panel to take people from what I believe is a nice approach from paralysis of the shoulder following potentially a plexus injury towards maybe an orthopedic-based injury or a trauma to the shoulder into what could happen with upper motor neuron injuries through spasticity approaches, into muscle tendon transfers, and then finally into rehab approaches. So I think hopefully it gives everyone something to learn from, maybe a new perspective to take, a new field of interest to kind of read more about. So to start, we'll have Dr. Tufaha out of Hopkins talk about core approaches to shoulder reinnervation following brachial plexus injuries. They'll have Johnny Liu talk about alternative spinal accessory approaches for brachial plexus. Adam Stroll from the Philly Hand to Shoulder Center will then talk about reinnervating the axillary nerve through other maybe orthopedic-based pathologies to help us understand what could be the underlying cause for poor shoulder function following orthopedic surgeries. Eugene will then take us through spasticity approaches for the shoulder. And then Dr. El-Hassan will talk about nerve functional muscle and tendon transfers following brachial plexus injury to the shoulder. And then Teresa at the end will take us through reinnervation approaches through rehab and kind of understanding the overall perspective of psychosocial health in these patient populations. So with that, let's have Dr. Tufaha start us off with core approaches to brachial plexus injuries for the shoulder.
All right, thanks so much, Neil. And thanks to all the organizers here for putting together this really interesting, timely topic for a webinar and for inviting me. Let me just pull up my talk here. All right, so I'm going to kick things off by talking about the topic of reanimating the shoulder after brachial plexus injury, and I'll be focusing on some of the standard techniques before Johnny Liu talks about some of the more alternative and I would say cutting edge approaches. So, it just so happens that I just got out of the OR a little bit ago, and I had a very interesting case that I think, serves to illustrate some of the complexities here. And so I'll first start by just kind of introducing this case, and I'll circle back to it at the end. So this was a 30-year-old male, otherwise healthy, motorcycle versus car accident 11 months ago. He had absent shoulder function, no deltoid, no external rotation, no supraspinatus, infraspinatus. He had M4 triceps, but no radial nerve function distal to that. Other than that, his motor function and sensory function was intact. And his history was also notable for a really bad scapulothoracic dissociation with a scapular fracture. He also had a bad humerus fracture with a plate. So, you can ponder that as I kind of go over these topics. So first, it's really important to recognize that shoulder function is complex, and there are many different muscles that contribute to what we see with global shoulder function. And so I've highlighted some of the main culprits that we usually focus most of our attention on in terms of targeting with in order to reanimate them. But if you get tunnel vision and you think about these things two-dimensionally, you will often find yourself failing despite doing a successful nerve reconstruction. If you miss a big picture, it can often result in suboptimal outcomes. So first and foremost, you want to set reasonable goals for both yourself and for the patient. Sometimes the best that we can hope for is to achieve dynamic stability of the glenohumeral joint. And even that, I think, is a win in some situations. You can, without this, when the patient has a very unstable glenohumeral joint, it can cause pain. It prevents them from having translation of the humerus with scapulothoracic motion. So if you can even just achieve dynamic stability, that can amount to meaningful improvement in shoulder function. But ideally, we'd like to restore some degree of active range of motion, but just keep in mind that we're not trying to restore normal. In my hands, if I get to 70 degrees or 90 degrees of abduction and forward flexion, that's a huge home run. So just to kind of frame expectations is important up front. And also thinking about things in terms of functions when you're talking to the patient, like, my hope is that I can help you, perform basic activities of daily living, like reaching up to grab a doorknob, in the best case scenario, getting your hand to your head, or, for shampooing and hygiene and feeding. You have to keep in mind that these are very large, high demand muscles. And so an M3 is really a lot of strength that you have to restore. And it can often take a long time, where sometimes we'll start to see some meaningful improvement at 6 months. In my experience, it often takes 18 months or longer before you can really judge your outcome. So you have to be patient, and you have to really remind the patient over and over again that this is going to take a long time. One of the critical considerations is the timing of your nerve reconstruction. Ideally, within the setting of a brachial plexus injury, I like to be in the 3 to 6 month range. Just given the nature of these injuries and the fact that we often have to watch them for a period of time to rule out spontaneous recovery, it's rare to do these before 3 months. But I like to kind of be on my toes and try to get in there without kind of waiting any longer than is needed. 6 to 9 months is okay. Once we get to the 9 to 12 month range, we start having the, kind of worth a shot, it won't burn any bridges, I'm willing to give it a go, but really setting low expectations. And then beyond 12 months, it's often, you have to really ask yourself whether it's worth even doing. And also, conversely, we always have to remember that if we have evidence that spontaneous recovery is very unlikely, there's no need to even wait 3 months. So we have to remember, why are we getting imaging? If we get an MRI and we see root avulsion injuries involving the upper trunk, I think that's a good indication to get in there right away. And, just in terms of patient selection and again, setting expectations, older patients we know are going to do less well. It doesn't mean I don't operate on older patients, but it just changes the algorithms and the discussion. And you have to kind of, be cognizant of severe structural damage to the shoulder. So these patients often don't come in with a focused shoulder MRI, but you should really consider getting that if you're going to try to reanimate the shoulder. So the most common injury pattern for a supraclavicular brachial plexus injury is an upper trunk C5, C6 injury. And it just so happens that causes complete shoulder paralysis with regards to abduction and forward flexion, as well as external rotation. And the question that you always have to ask yourself, kind of one of the big picture questions, is, are you going to graft from a viable root or trunk or cord, or are you going to go right to distal nerve transfers? And that's something that I'll touch on later. Actually, I'll touch on it now. So the big picture, or the take-home point here is that both are very reasonable options. And in my opinion, you should leave both options open by starting with a exploration of the brachial plexus before you go right to the distal transfers. Even if you end up finding yourself with a viable donor nerve stump to graft from. It doesn't mean that you have to do it, but it just allows you to kind of take inventory and consider what the best approach is going to be. There was a good systematic review by Scott Wolf in 2011 that did suggest that dual nerve transfers were better than grafting, but there have been many series that I think maybe were better controlled, showing equivalence. And it's so hard to control for all the different variables here. And I think it's fair to say that both are reasonable, both should be in your wheelhouse, and you have to just kind of take it on a case-by-case basis. When we think about the nerve transfers for upper plexus injury, by far the most common ones that you need to be aware of are triceps to axillary and spinal accessory to suprascapular. So starting with triceps to axillary, this is often referred to as the SOMSAC transfer after the person who's given credit for describing it, SOMSAC Lichabangbang. And he had 7 patients in his initial series, all of whom had M4 recovery. He used the long head, a branch of the long head as his donor. Average follow-up was 20 months, which I think is an appropriate follow-up for this type of transfer. You know, since then, there have been many modifications, many series. This is one of the better described nerve transfers in terms of outcomes and longevity. You can use 1 or 2 donor nerves, and really any of the 3 triceps branches are reasonable donors. And, you know, I think the data is very equivocal. I don't think there's strong data to kind of push you towards kind of really prioritizing one branch over the other. The medial triceps branch is longer, so you know that offers some advantages. You know, some people have concerns about taking the long head because of stability of the shoulder, but I think there's enough evidence to support use of any of them, and I'll often use 2. The other major consideration is whether you're going to go posterior or anterior. So this is a illustration of how I do the posterior approach. I do it in supine, although a lot of people do it in prone. And basically, I have the shoulder elevated 90 degrees, and then internally rotated, elbow flexed, and then I'll have the hand sitting on a sterile mayo that's padded or pillows on the chest. And I like it because it kind of opens up the quadrangular space nicely, and it avoids the need to flip the patient. And you can see here up top the triceps branches. This is a triceps branch of the medial head. And then down below the teres major, you can see the axillary nerve. And you can see that, you know, this posterior approach allows you to really lay out all the distances nicely. In the posterior division, you have the branch going to the posterior head of the deltoid, the sensory branch, and then coming off more proximally going to the teres minor, and then the anterior division going to the anterior and middle deltoid. And you know, the anterior approach also is something that you want to have in your wheelhouse. It does open up the option of having other donors that you can use in addition to the triceps branch. You can see here that I have the white vessel loop around the axillary nerve, and then the pickup is picking up the very proximal branch off the radial nerve, going to the long head and the medial head. And so you can imagine how easy it would be to take that branch and transfer it to the axillary nerve. And if you follow that just below the latissimus tendon, you can actually see a branch into the anterior and posterior divisions. It's not as easy to target individual branches, though, so that's one of the advantages of going posterior. And also, posterior allows you to bypass any injury that's happening further distal along the axillary nerve, and that's particularly important with isolated axillary nerve palsies, you know, in the setting of dislocations or iatrogenic injuries. In that case, you probably want to go posterior so that you can not transfer axons into injured axillary nerve. So, as with all nerve transfers, you always want to have a strong donor, minimum of M4 or, you know, ideally M5. even when the muscle is strong, the donor muscle, keep in mind that you can have partial denervation with compensatory collateral regeneration that will give you what seems like an M4 or M5, but with far fewer axons. And there's a nice study again by Scott Wolf showing that if you have denervation changes on the EMG, even with a strong donor, that it can downgrade your outcomes, which is not surprising to me. And I think that's something you want to keep in mind for all nerve transfers. Another important question is, are you going to go end to end or end to side? Since I'm focusing on brachial plexus injuries, I'm just going to say that, you know, you're almost always going to go end to end with a brachial plexus injury because you're usually intervening when you've ruled out spontaneous recovery. And if there's ongoing spontaneous recovery happening, you're likely going to pump the brakes. But I often go end to side in the setting of isolated axillary palsies, but I think we're going to talk about that later. And, you know, you have to be thoughtful about which targets you're going to pick from the axillary nerve. Anterior division is often the best target, but, you know, if you want to prioritize external rotation, you should target teres minor. And I've kind of migrated towards taking two branches and targeting both individually. And I don't have any patients with noticeable triceps weakness. So moving on to spinal accessory to suprascapular nerve transfer. This is a good nerve transfer, but in comparison to other commonly used nerve transfers, there is some concern about the consistency. And I think you're less likely to get a home run outcome with this. And it's probably because of the issue of having a distal segmental injury at the suprascapular notch. There's also some concern about the downsides of denervating the middle and lower trapezius. You always spare the upper trapezius, whether you're going anterior or posterior. But, you know, by definition, you're going to end up denervating much of the middle and lower trap. And that can have some consequences with regards to scapulothoracic motion. And, you know, particularly if you're relying on that in the setting of a secondary shoulder fusion, there's no data to support this, but I think there's strong kind of theoretical concerns to keep in mind. And so there's a growing trend I've seen towards avoiding this nerve transfer if there are any concerns for, you know, kind of major injury to the shoulder, similar to the patient that I had today. And, you know, the posterior approach, which was described by Baum, McKinnon, and Kohler, had a nice paper describing it and combining it with the triceps to axillary. That has a lot of upside because it allows you direct access to the suprascapular notch, so you can identify an injury by decompressing the nerve at the notch and then bypass that kind of distal segmental injury zone. But Bertelli actually has a nice paper that he published recently showing that you can achieve that same aim from an anterior approach if you do a clavicular osteotomy to take down the insertion of the trapezius. So that's worth checking out. And this is just showing kind of the anterior approach here and the posterior approach where you can see kind of it's really, it's challenging. It's a deep hole, but it does give you really nice access to the nerve at the suprascapular notch and gives you some kind of peace of mind to know that if the nerve is injured there, which it often is, that you can bypass that. And so, you know, this was all talking about upper trunk injuries, but, you know, I just want to point out that if you have an extended upper trunk or a pan plexus injury, things are much more challenging because you don't have that triceps donor to target the axillary nerve. In those situations, I like to go through the axillary anterior approach, and I'll use intercostals, a median fascicle, medial pectoral nerve. This is an example of using intercostals to the axillary nerve, which works well. If you have a pan plexus injury, you're even more likely to have suprascapular nerve injury distally, and I think the outcomes are less likely to be satisfactory. And I think sometimes with these patients, given the paucity of donors and the whole scenario, it's okay to just settle for a shoulder fusion up front, in my opinion. This is just, I'm going to skip this here. So going back to my case today, when we explored the supraclavicular plexus, the suprascapular nerve looked okay. Then when we went posterior, everything was kind of obliterated where the fracture was, and there was no target for the suprascapular nerve. Through the axillary approach, which you can see here, white vessel loop around the axillary nerve, the nerve actually looked okay here. As we followed it proximally, there was a neuroma at the takeoff from the posterior cord. So this was a distraction injury from the dislocation, with most of the force, really, most of the injury being focused on the takeoff from the posterior cord. So the patient, again, didn't have distal radial nerve function, distal to the triceps. The triceps were downgraded, so we couldn't use those. So what we ended up doing was taking the radial nerve, sparing all of the triceps branches and transferring the rest of the radial nerve, which presumably had axons in it, to the axillary nerve. And best case scenario for this patient is that he's going to get a strong deltoid and teres minor. But maybe after that, if we get that far, maybe he could get a reverse total shoulder and kind of optimize the biomechanics of the joint itself and get reasonable function. Or maybe he'll settle for having good dynamic stability to allow for his good scapular motion to translate to the humerus. Thank you.
Amazing, Sammy. Thanks for that. A lot of great thoughts and really interesting case there. Well, next we'll have Johnny take it over with kind of what Sammy had alluded to, other potential donors for transfers.
Do you guys see what I have, Neil?
Full screen looks good. Nice.
Okay, all right. Thank you so much. It's an honor to be, part of this series, and we have excellent group of speakers. So thank you so much, AAHS and ASPN, for this great invite. I think mainly what Sammy had covered are things that are probably going to be useful, for like 80% of the time. So I'm going to be talking about alternatives that we do. They're not necessarily going to be popular. They're not necessarily going to use, but in the spectrum of brachial plexus, you're always good to think about other choices that you can consider. So, why preserve it? Why not use? And I think Sammy alluded to this previously in the slides, is that when you have a panbrachial plexus or C5C8, you just don't have enough donors, but you have an overwhelming number of functions that you need to take care of. In panbrachial plexus, spinal accessory is one of the most potent neurotizers. And the trapezius muscle, it's sometimes kind of overlooked and how important it is. So, I'm looking forward to Basim's talk about the shoulder muscles are related. I believe that it is a important stabilizer of the scapulothoracic articulation. And in panplexus, often you have a denervated serratus anterior, even a rhomboid, which really takes out that stability. So spinal accessory, it is a great nerve, but usually I preserve it in these more severe injuries. And like this, when we have these panbrachial plexus, they definitely take about the majority of my plexus cases. I would say 60%, 60 to 70. And so, I don't really have the luxury of really going after, do the SUMSAC and the spinal accessory to suprascapular. Those are nice procedures to do, but they're just not always available for me. And as we've shown here, it's a very, very vital thing that you could use for functioning muscles. Something that Dr. Allison has presented before, using the trapezius also for the shoulder. I think that actually gains even more importance in the brachial plexus injuries. And then where there has been studies that have shown that shoulder arthrodesis, especially for these brachial plexus, can mimic or even overcome when you compare them to the nerve transfers. So for me, my go-to options, are the following when I encounter these cases. And first two are the ones that I tend to do the most. I will give mention really quickly to the other ones that have been done before. Here. So first one is phrenic nerve, and it's a very popular nerve that we use here in Taiwan. I'm not going to take my time to really, tell you to use it or convince you, but it's just something that we do here. We always do the chest X-ray inspiration, expiration to kind of look over the function of the phrenic. But often you have to say that in a lot of panbrachial plexus, I would say 40–50% of the time, the phrenic is already injured or already disrupted. So And then we begin to use for the past like 3 to 4 years using the chest ultrasound and pulmonary function tests to kind of help us evaluate what's going on. And so if that tells us that, the pulmonary function is not doing well, there's a lack of diaphragm movement, of course we're not going to use that nerve. And already we will see the patients as they are, but rarely are they already in shortness of breath. So this case is a case that more of a C5 C6 injury. When we did the exploration, as you can see here, the C5 C6, I think it was avulsed proximally. But as you can see in the picture on the left, the phrenic is actually very, very obvious. It's very, very helpful that I don't need to do additional dissection into this, as Sammy had presented laterally to go after the spinal accessory. The phrenic is literally right there. In a young patient, I think it's very helpful. I combined this with the SUMSAC procedure, and I got outcomes that I feel was quite good. All right. Another case of a C5C6 avulsion, as you can see with the dermatome being affected. This is where I actually use both nerves. I use the phrenic and the spinal accessory. The C5C6 were both avulsed. I proceeded to not do the SUMSAC in this procedure because I used the C7 posterior division to go to the anterior division of my upper trunk to do elbow flexion. The convenience of this is I didn't need any extra additional incision. I used the C7 as it is, and then both donor nerves. And I felt that for this case, definitely the shoulder was definitely much more improved, gaining that functional strength that, that Sammy alluded to before. But please recognize that these are C5, C6 injuries. The less roots are involved, the less likely they're going to have trauma to the musculoskeletal system. There's a reason why these cases do so well. Yeah, and you can see that with this, when you have a C5, C6, 80%, 90% of the time you want a functional outcome for these cases. Another C5, C6 avulsion or MRI kind of gave an idea that the C5 might be able to be used, but it's not like a particular good stump. And so as you can see, you find a nice C5 stump, but you trim it a little bit more and you see the mushroom, but again, it's not a really good stump. So in this case, I proceeded to not use the spinal accessory at the same time, but I proceeded to use the C5, which I thought was still valuable. And I hooked up to the distal C5 in addition with the double fascicular transfer. And I have to say, though, this case really worked very, very hard. The outcomes, I don't really quite agree with what Sammy was saying about the 18 month thing. You kind of know the outcomes. You can predict the outcomes by 12 months, but usually you follow up these cases, and every year this case got more stronger and stronger. Again, I want to emphasize that this is a C5, C6 injuries. There's a lot going on with around the shoulder that are functional that allows them to do this. So we published on this in JHS, and in these outcomes, and these are usually in brachial plexus injuries with multiple root injuries, so not just C5, C6, but more severe ones. And we compared strictly use of phrenic nerve as an isolated donor versus the spinal accessory, and we found that there were quite equivocal outcomes. And there's a difference between, sorry about this, okay. There's a difference between the use of the phrenic and the intercostal nerve. The phrenic is definitely the start of the inspiration. So this is a panbrachial plexus where I use both the phrenic and the intercostal. You could see that the intercostal tends to come a little bit later. This is a study that we worked with Mariano, but I just ignored this. There's another figure in this. C5, C6 avulsion, again, similar to what I presented before, but in this case, I did a SUMSAC along with the phrenic nerve. And I felt this case got the good external rotation that we would need. Again, in the panbrachial plexus, where I would preserve the spinal accessory for further uses, I used the phrenic in this instance as the isolated only donor. You can see that the shoulder abduction was evident. There is definitely less external rotation, but again, for these panbrachial plexus, even some form of shoulder abduction would be useful. Again, in another panbrachial plexus injury where I only had one donor of the phrenic nerve, you could see that the shoulder for him was actually quite acceptable. This is another case, C5T1 panbrachial plexus, where I used only the phrenic. But I think this case was actually a bit more There were things with him going on with him that I couldn't really explain because he was very, very active in trying to use his hand, and he uses his hand in his occupation. And I think this is a very, very valuable component, which I think we're going to talk about later with physiotherapy, is that when the patient really wants to use that hand, the outcomes also is a great, a push to get a better innovation. Okay. So we kind of compared when Mariano Sokolovsky, who's a neurosurgeon in Argentina who also uses the Phrenic quite often. We kind of compared and look at our outcomes they like to use it for the elbow, I like to use it for the shoulder, and in looking at the comparison between the two outcomes, and we published this actually just quite recently in that to get a good outcome, you need operation age and BMI, and also time from injury to surgery as critical factors. So I really want to emphasize that the age and the BMI is a critical factor. So there are donor side morbidities. I'm not going to try and hide that. We did look at the lung function post-operatively. It is worse after the surgery, but patients symptomatically do say that they feel better after about 6 months. So there is a decreased lung capacity, shortness of breath, and it is contraindicated in neonates, patients with very obese, and also at old age. My personal experience with the respiratory donors is that I think when you use it, you encourage the patient as a part of your physical therapy, you encourage them to move. And I think exercise is very good for the body, for the patients. And I've noticed that when they exercise more, when they try to climb stairs to initiate that phrenic, even though they are initially shortness of breath, that actually pushes them. So I think relative contraindications where I've seen it fail are patients who are in severe pain, patients who lack rehab, and patients who tend to have shorter necks. I do also another alternative that I like to do is the root grafting from the C5, and it's important to actually know, how to evaluate if you have a ruptured versus a valse stump. And I think with this figure that we use, that I use for all my patients, the Tennelle sign, whether you have a PM, whether you have an intact rhomboid or levator, whether or not the patient is in pain, are things that can help you to evaluate if you have a ruptured stump or not. We also like to use the MRI, and I think people who know me, who talk to me, know that we use the MRI very, very extensively, especially the Fiesta view, to really help us determine the quality of that stump, which we have found very, very useful. And in our center, we use it much more than intraoperative stimulation, such as SSEP or MEP. And so this is a case again with the C5 being able to have a ruptured stump, and we actually hooked it up to be able to hook up from the ruptured roots strictly by grafting. That does take longer, I can't deny that. But with the outcomes, probably after 2 years to 3 years, it gets better more and more every year. But it is definitely not a home run. So I would not really consider telling you that it is the number one thing to do. I think nerve transfers still have more roles in this. Now I'm going to get into the ones that I have tried out and I'm going to share with you. But again, so I'm going to provide my kind of feedback. The number one is the intercostal nerve. So intercostal nerve, when you use for elbow flexion, you do have good outcomes. But because here for our panbrachial plexus, I use other forms of reconstruction for the elbow flexion. So I do tend to use the intercostals for more of a posterior function, such as the axillary and the triceps function. And I find this to be very, very helpful when I use the two nerves from intercostal third and fourth, and then fifth and sixth to the triceps branch. Interestingly, though, from my my outcomes, I didn't really get, this one had a spinal accessory to suprascapular, but the intercostals in this instance to the axillary didn't really provide the feedback that I thought would be helpful. But interestingly, though, the intercostal to the triceps actually worked very, very well. And that was one of the instances for these panbrachial plexus injuries to, kind of inform me that, hey, it might be, the axillary nerve might be just too large for the intercostals to innervate. This is another case. I think it was a C5, C8 injury where I did the intercostal along with the phrenic nerve to be used. But again, you could see from this, it's a C5, C8 injury. The shoulder is just not acceptable. So again, I'm a little bit hesitant about using the intercostal for axillary. I've done about, I think, 3 cases. I don't really feel like I really feel comfortable in using this for axillary. I would still do it if I had no other donors. But just to show you though, this is for Sammy. The ECRB, the PQ branch to ECRB works great. It's fantastic. But again, for shoulder, it's just so much harder. So this kind of puzzles me because that donor is actually an injured donor, whereas the intercostal in this donor was much better, but the outcomes are just much different. I do have experiences using the medial pectoral. I'll almost finished, sorry, with the time. C5, C8 injury, C5, C7 injuries. Again, the triceps was just too weak. So I wasn't able to use the SumSac. So I proceeded to use the medial pectoral nerve to innervate the axillary nerve along with the spinal accessory to suprascapular. And this was an instance where I felt like quite comfortable. I was like, oh, this is a good transfer. I think I'm going to get a good outcome. But as you can see here, I think the spinal accessory worked, but then I don't think my medial pectoral really worked that well. And so, but fortunately, he had a great elbow flexion. His elbow flexion was really good. So it actually got better than this even, but he still had some external rotation and he was able to work with that spinal accessory to suprascapular alone. Another case like this where I was, forced to use the medial pectoral nerve and then I hooked up to the axillary. So usually the location in which you do the coaptation would be somewhere in the deltoid pectoral triangle. And then you hook it up to the axillary. It's a great, coaptation, but, the loss to follow-up. Patients never came back. There are other options suggested here. I invite you to read them. Dr. Boubier mentions using the levator scapula if you do a posterior approach. I've tried doing this. It's a little bit hard to get that nerve out. Scott Wolf described this using the levator scapular motor nerve. We've used this before, but I don't think it's enough for the suprascapular alone. I think you need other nerves to help out. The transfer the C7 fascicle, I did one case of this. The patient never came back, so I can't really judge that. And then from it's something that I know has been published before using the FCU branch from the ulnar nerve to the axillary nerve. I've never done this, but this is something that probably is also available to you. And then coming back to shoulder arthrodesis, I really want to highlight this is one of the cases where I felt very comfortable with the nerve transfers, but the patient didn't really make me feel comfortable because of how old he is and also, so much had been done, so the nerve transfers never really worked for him. So if you look at the left, all the nerve transfer that I did, none of them worked. And so this is where it was very troubling. But because there was so much dissociation with the glenohumeral joint, I proceeded to actually, do the shoulder arthrodesis and just look at that, the elbow flexion improve. You can sense my excitement from that. So I think coming back to this, I mentioned all these alternatives, but please recognize that, that when the more severe the injuries, you're forced to use these other nerves. And there's so much more trauma and there's so much limitations that it makes it really hard to compare. And that's why I think when you use the alternatives, it's hard to compare to the original one, the spinal accessory. So I can still safely say that I feel the phrenic nerve is still something that I think it's comparable to the spinal accessory nerve. But usually, spinal accessory is still very valuable. I do have to really, really emphasize concomitant musculoskeletal injury is very important. If you have that, then you have to really rethink your neurotization. Last thing I just want to mention, please remember to document. That's always the number one thing when you come back to look at your cases and your pictures intraoperatively. It can really help you out. Please join the meeting, AHS and ASPN. I think the abstract submission is soon. So thank you so much.
Incredible, Johnny. Incredible cases there. Thank you for sharing all that. Adam, take it away.
Oh, I think you're muted.
That was weird. Sorry about that. Great. Sorry about that. Thanks for the invitation to be part of this. It's a great collaboration, and I love this topic. It's something that we've really focused on in the last 5 years. It's addressing shoulder problems, particularly iatrogenic after arthroplasty. These are my disclosures. And I'd be remiss to not call on my partners here, Matt Wilson and Ken Kearns. Not only are they my best friends, but we have an amazing trio. We get to do complex surgeries together and hang out. But I'm a plastic surgeon with hand training. Matt Wilson's an orthopedic surgeon with hand training, and Ken's an orthopedic surgeon with shoulder elbow training. So we really approach this from all angles. And there's a topic that is near and dear to us that's finally coming to fruition. So where does it come from? As you probably know, there's a lot of orthopedic practices in the greater Philadelphia area. And within those practices, there's quite a few shoulder elbow surgeons that are quite notable. And it's not uncommon that one really good surgeon has a patient that goes to another really good notable surgeon for another opinion, particularly when there's a complication or a quote other than expected clinical course. And essentially, a lot of times the one surgeon will just confirm that the hardware looks appropriate, appropriately positioned, appropriate selection. Sometimes there's poly exchanges for suspected subclinical infection that may not really gain much improvement. So really this question came about, why do some of these patients just not do well post-operatively, particularly after reverse shoulder arthroplasty? I don't think we need to harp on this. We know the axillary nerve comes off the posterior division. And this is the most important part, is that quadrangular space as it goes from anterior to posterior, and knowing the boundaries of the quadrangular space. And more importantly, knowing how close it is to the joint capsule. And for all the orthopedic surgeons and arthroplasty surgeons that may see this, you all know this, you feel it, you see it arthroscopically, like you can see on the right during capsulotomy, which is just incredible. It makes me kind of shake a little bit seeing that. But it is very, very close to the joint capsule, which is essentially, and to the surgical neck of the humerus, which poses the question about what can happen to this axillary nerve. So when does the axillary nerve get injured, other than talking about brachial plexus, but certainly glenohumeral fracture dislocation, proximal humerus fracture, blunt force trauma, traction injuries, brachial plexus. And really the large part of this has become iatrogenic causes, whether it's total shoulder or reverse total shoulder arthroplasty. So here's a great case example of a 53-year-old gentleman. He already has left-sided paresis from a remote TBI many years ago. He's up on his roof and falls off his roof and has a proximal humerus fracture. And soon after that, typical course, right? A month later, things sort of settle in, and there's an attempt at an ORF for the proximal humerus. This goes on to have tremendous heterotopic ossification with glenohumeral arthritis, ankylosis of the joint. And this notable shoulder surgeon decides to then convert and to a reverse shoulder arthroplasty. And you can see the x-rays that are there. Certainly a lot going on within this shoulder. He's an active guy. Not only is he on anticoagulation, which poses some problems in the TBI in the past for the heterotopic ossification, but he's active. He gardens. He's a psychotherapist. He does yard work. And 6 months after his reverse, he doesn't have too much pain at rest, except an ache that he describes. But if he tries to move his shoulder, which is why he had the shoulder arthroplasty in the first place, he starts having a lot of pain. And he has difficult time driving. He can't dress. He can't groom. You can see his physical exam score here. He has limited abduction, actively particularly, but passively as well, and has pain with that terminal limits of abduction and forward flexion. And when you palpate the three heads of the deltoid, they're weak, but they're palpable. And he has tenderness notably posteriorly in the quadrangular space with decreased sensibility over the lateral shoulder. He has an electrodiagnostic study that clearly shows there's a posterior cord injury, and mostly the deltoid. You could see very minimal fibrillations and motor unit action potentials, or fibrillations, motor unit action potentials, suggesting that he has a significant injury at his axillary nerve and that there is recovery, but there's probably more to the question. So what we really nodded to was actually a paper Jesse Jupiter put forth in 2001. And the question is, why did elbows that have really good fixation and had good bony union not do well after those surgeries? And it was Jupiter and colleagues who recognized that it was the ulnar nerve that was entrapped or on traction, compressed, and that this leads to pain and dysfunction. The patients have neuropathic pain. They get limited motion of their shoulder. They can't tolerate therapy despite having a good attitude and attendance to therapy. And it's a setup for a painful elbow contracture. So similarly speaking, why do some shoulders not do well after joint reduction or ORIF of a proximal humerus or shoulder arthroplasty? Well, you can conjecture that there's traction, there's compression of the axillary nerve that leads to pain and dysfunction. There's narrowing of the quadrangular space. The neuropathic pain sets up to have limited motion despite a motivated patient that attends therapy, and they have a setup for painful shoulder contracture. Just to comment on this, I am a believer in the scratch collapse test. We don't have to go too much into it, but I do wonder that if an axillary nerve is on stretch and you stretch it more, is there some sort of mediated substance P or histamine factors that sort of inhibit the nerve on itself, or is it just pain? I'm not sure if it's a reflex arc, but I imagine that nerves that are on stretch don't function very well. So what's happening here? Our theory is that there's been bleeding, probably from the initial trauma of the proximal humerus, as in this case. Then they go on to have more surgery. There's scarring around the nerve. There's limited excursion, particularly at surgery at the time when they're in therapy and they're trying to move their shoulder. They're saying, ow, 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 that's it. Well, when they're under general anesthesia, they're not saying ow, ow, ow anymore. And you can get to the limits of a traction injury or even worse, a rupture. There could be narrowing of the quadrangular space, either from scar or from the base plate itself, from the arthroplasty, that can lead to changes within the space and the axillary nerve. There's pain that's secondary to nerve compression, as we were just commenting on. And is there some sort of reflex arc? I don't know. But these patients get painful shoulders, worse with motion, limited range of motion. They can't tolerate therapy, and they have weak deltoid function, even if their deltoid is firing, whether they had an injury that's recovered or they didn't really have a tremendous injury. So what have we done for these patients? We typically put them prone. I will say we sometimes do beach chair. It could be a major PIA to do that in terms of cranking your neck around to get posterior. But if we are going to go anterior as well, or do something like a thoracic outlet release at the same time, it is helpful instead of flipping the patient twice. We decompress the quadrangular space. We dissect out all the branches. We do stimulate it. No disclosure needed. I do use a checkpoint based on the protocol for 10 minutes. We often will do a nerve transfer end to side, occasionally end to end if there is no contraction and it's been greater than 6 months. We have been using a scar barrier. There was a disclosure there with Versarap. I've been happy with it. I'm happy to talk more about it. Why? I'll just move along for timing. What do we often find? Pretty significant scar planes that obscure the axillary nerve. It's difficult to even find it at first. When you do find the quadrangular space and you follow it in from the sensory branch, you can barely put your finger into the quadrangular space. There's really a hard stop. Sometimes you can feel palpable hardware. You don't see it, but you can feel the base plate nearby. And the proper axillary nerve is often typically adherent superiorly to the joint capsule, and the branches are adherent as well. And occasionally, as this case on the right side, we'll actually find evidence of a rupture of the axillary nerve, which clearly will never recover and needs to be addressed. How do these patients do postoperatively? We find that there's a significant reduction in their pain, particularly posterior pain, and it's often immediately post-op. They can improve, they can report improvements in sensibility. They start tolerating therapy more, particularly with passive range of motion. And with time, they will start having improvements in their abduction, particularly in tasks they couldn't do, driving, shaking hands, things like that. So in this case, this guy told us that after surgery, he never had more than 1 out of 10. At 6 months, he started having improvements in abduction and forward flexion. He reported being able to put his own seatbelt on. Remember, his left side is paretic, so that was a big deal for him. Here's just a video I'll show real fast.
Go ahead and try to raise your shoulder up as high as you can like you did before.
So we're holding down, trying to limit scapulothoracic.
Good, and down. And let's show some resistance.
So
And here's the fellow that'll
hold it to the
basically
side, hold it to the side right
hang
here,
on his
hold it
arm.
and break you down.
Strong, 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 strong.
I mean, I'm leaning with my body weight.
So tell me again.
Unfortunately, the other video is pretty cute. I'll just save it for timing, but he talks about how his wife hides the good candy bars at the top shelf of the refrigerator, but now he can get to them, so she's not too happy about it. Anyways, where are we going from here? So Matt, Ken, and I We're looking at our patients. We've done a few dozen of these now. We're trying to stratify them about when's the best time, either pre or post, risk factors for it. We also have a biomechanical study that was presented at IFESH, looking at the cross-sectional area using ultrasound and visually looking at stretch of the nerve for a tethered, trying to make up a scenario whereas if it's tethered at the quadrangular space with different componentry of the reverse arthroplasty. And I'll leave it at that. But thanks to Ken and Matt for sure, and some other people. CJ Nasrallo is at MGH now as an attending, helped us with it when he was doing our fellowship, and some medical students.
That's great work, Adam. I think really attention to this underdiagnosed pathology that we're seeing with the increase in shoulder elbow work over the country. Okay, Eugene, please take it away, kind of changing gears towards our spasticity cohort.
All right, so thanks so much for that. And I'll be switching it up quite a bit here. I'll be talking about nerve approaches to spasticity management in the shoulder, which oftentimes tend to be ignored. So this will be a good opportunity. This is a typical posture when you see someone with spasticity. I work primarily in children, so we're dealing with cerebral palsy most of the time. So you have shoulder adduction, internal rotation, and you have flexion basically distal to that. So the shoulder, the adductor and internal rotators are primarily the pectoralis, the latissimus, and the teres major. And the external rotators are the posterior head of the deltoid, the teres minor, and the infraspinatus. These all play into the different deformities and impairments in spasticity, so we'll talk about that in a sec. But primarily, the major impairing deformity is going to be that of adduction and internal rotation deformity slash contracture. It really decreases the amount that the patient is able to reach. It impairs hygiene by the caregiver. And I have seen at least 2 or 3 cases where caregivers, including parents, are trying to dress the child and they'll accidentally fracture the humerus and really trying to crank on the elbow and shoulder. So historically, what have we been able to do is to really work on the bone, muscles, and tendons. That is to lengthen the pectoralis or subscap. But what we found is that there's really a lot of recurrence, and those of you who have tried this will probably agree. You could completely release the pectoralis, which tends to be the major deforming first, but you tend to get this balled up bunch of pectoralis that causes a cosmetic deformity. And with continuous spasticity, a lot of these patients actually get quite a bit of discomfort. For internal rotation contractures, you could do a humeral rotation osteotomy. And for the pectoralis, you could also do a complete neurotomy, as we do sometimes with breast deformity after breast reconstruction. But over the last 10 to 15 years, selective neurectomy has become a really powerful tool to decrease spasticity. It preserves volitional control of the muscles, but it spreads out a decrease in the actual underlying spasticity. So here we have a 7-year-old female. She's a spastic quad from Zika. She does have preserved passive range of motion if you really crank on her hard. So I'll call that a Ashworth 3 of their shoulder adductors. But the primary problem is that her parents really have a difficult time taking care of her, can't put on clothes, have a hard time washing her. So what we aim to do here is to do a selective neurectomy of the adductors of the shoulder, the pec major, the latissimus, and the teres major. What we do, and I'll try to justify my approach here, but we do a infraclavicular approach to the pec because I want to get as distal as possible on those pectoralis nerves. So we divide the clavicular and sternal heads of the pec, and we find major motor branches going into both heads. We confirm the identity of the nerves using a nerve stimulator. And we perform a distal selective neurectomy. And the reason that we're going distal really has to do with the principle of hyperselective neurectomy. You're making sure that you distribute that denervation across the breadth of the muscle, and this helps to decrease recurrence, and you're trying to decrease the possibility of a catastrophic complete denervation. So for the latissimus and teres, we do a posterior axillary line incision. Again, here we're identifying the thoracodorsal nerve and the lower subscap to the teres major. And again, we dissect distally. So I'll show you this in video form. So here we have a patient who has spastic deformity of the shoulder and adduction. We're doing the infraclavicular approach, raising a flap of full thickness skin to identify that interval between the sternal and clavicular heads of the pectoralis major. So here you always see this fat stripe between the two heads of muscle, and this will be pretty familiar to those of you who do TMR. We're dissecting carefully between the two heads. And deep within the space, you're going to see the thoracocriminal vessels, and around there is where you're going to find the nerves. So it's really helpful to have a nerve stimulator. You scan a little bit because sometimes it tends to be buried within the fat, but you identify the major motor branches coming off of the ansa pectoralis. Here we see two major branches to the sternal head of pec, and then one major branch to the clavicular head there. Again, we're confirming the identity using the nerve stimulator, and then dissecting distally to make sure we get to the nerve where it arborizes into its individual fascicles. So here you can see just how distal we're dissecting these nerves. We're dissecting them until they insert into muscle. You could see the individual fascicles that we've divided out. And for those of you who are familiar with this technique, you want to take about 80% of these fascicles. The remaining fifth of the nerve is enough to sprout, do terminal sprouting to keep your volitional innervation of the muscles. But this allows you to really disrupt that uninhibited reflex arc that causes spasticity. So here now we're on the other major motor branch to the sternal head of pec, dissecting distally. And then here we have the clavicular head, again showing the arborization of nerve as you go distally. So once you're done with that, you close, and then we're going to move on to the latissimus, again, the posterior axillary line incision. Dissecting on the anterior surface of the latissimus as you would a flap. And here you identify the thoracodorsal nerve. Confirm the identity using a nerve stimulator. And you're going to dissect distally until the nerves divide into fascicles. And you want to kind of get these as they're inserting into muscle. And branches to the teres major. Same thing, dissecting distally, dividing them into fascicles, and resecting roughly 80%. Sometimes you only end up with 2 or 3 fascicles, so you want to just kind of take the majority of them, basically. All right. So this is a patient who had selective neurectomy of the shoulder adductors on one side and not on the other. Basically, it's about an MAS3 on one side and an MAS1 on the treated side, which really helped the mother a lot in taking care of her. So, the important question comes down to why this procedure versus the others. And the reason for me has been that in the beginning, when I was doing complete pectoralis neurectomy, sometimes you get a little bit too much relief of that spasticity, which sounds kind of ironic, but I'll show you a video because some of that adduction tone actually is quite important when you're taking care of children because that allows the caregiver to pick them up from under the axilla without slipping through. So the selective neurectomy actually preserves some of that volitional control of adduction. And I found that that's quite important for caregivers. So this is a patient who's had a complete pectoralis neurotomy. This on the left side is untreated. As you can see, he's about an MAS 2 to 3, but on the right side is just pretty flail. And the mom, unfortunately, had a pretty hard time picking him up from under the armpits because of this. So how about the external rotation deformity? You see this a little bit more in children versus adults with upper motor neuron disease. But this is a combination of dystonia as well as spasticity. And children who have this deformity tend to have some difficulty getting through doorways. It's quite uncomfortable. So we have attempted to use selective neurectomy to treat this as well. So this is a 17-year-old male. He's got CP with a mixed motion disorder. Again, he has preserved passive range of motion, but really very limited ability to volitionally internally rotate the shoulder. So here we see his resting posture. He was basically living like this most of the time. And I'm showing here that he has preserved passive range of motion to be able to bring his shoulder past neutral toward midline. So the way that we've approached this is to do a posterior shoulder approach where we're going to address the nerves to the posterior head of deltoid, the teres minor, as well as infraspinatus. So we raise a big skin flap and we actually disinsert a part of the posterior deltoid, giving us access into the quadrangular space. And we are dissecting out now the axillary nerve, the branch of teres, as well as to the posterior division. And we're going to loop them and confirm their identity using the nerve stimulator, as we see here. And same thing for the infraspinatus. We're going to find the distal extension of the suprascapular nerve as it goes through the spinal glenoid fossa. So you have to get deep to the surface of the infraspinatus. We dissect it off of the scapular spine. And in that space, you're going to see the suprascapular nerve and its extension coming through the spinal glenoid fossa. There's a nerve right there. And again, confirming the identity with nerve stimulation. Here it fires the infraspinatus. And again, for all three of these nerves, we're doing the exact same thing. We're dissecting distally. We're looking for them to arborize into fascicles. And we're resecting about 80% of them as they insert into muscle. So you can see the arborization of the nerve there pretty well. Again, resecting a segment of the nerve as it inserts into muscle. And then afterward, you repair the posterior deltoid, close skin. And then so here we see that he's now able to maintain a better resting posture. He's maintained volitional external rotation, but importantly, he's able to bring that shoulder into internal rotation with some effort. There's a lot of component of dystonia to this, so you can't completely get rid of that posture, but it really does help. With continued therapy, the amount of time that they spend in internal rotation actually increases quite a bit. So that therapy afterward is quite important. So post-operatively, after selective neurectomy, there's really no rehab that's necessary. You're just waiting for that incision to heal. So we have soft dressings. So this becomes really important for children, really, who have cognitive impairments or who are too young to deal with post-operative therapy. So that's been really beneficial for that population as well. All right, so thank you very much. And that was the nerve approaches to spasticity of the shoulder.
Great videos, Eugene. Thank you for sharing those. That's great to see. All right, Dr. Al-Hassan can change gears yet again, but this is going to be great. Thank you. I think we may be muted.
All right. So again, like I'm going through the shoulder anatomy and biomechanics, very, very simple, very basic. The shoulder joint, this is in a very simplistic way. 2/3 glenohumeral motion and the rest is scapulothoracic. This will be important later when we talk about certain type of muscle transfer. And there are 6 muscles that surround the scapulothoracic articulation. The two most important ones are the trapezius and the serratus, but we also have levator scapular rhomboid minor and rhomboid major. And from the front, you have pectoralis minor as well. And other than that, from anterior to posterior, we have the rotator cuff with the deltoid. Like the posterior rotator cuff are the infraspinatus and the teres minor and top supraspinatus and the front subscap. And we have the deltoid. Now, from this, that's very simple. Perfect deltoid, perfect rotator cuff. Scapula is unstable. You can have very limited range of motion of your shoulder. So the scapula has to be stable. Patient has no deltoid whatsoever. has perfect rotator cuff, he can have full range of motion. And even the standard rotator cuff testing, the Joe test and stuff like this, you cannot detect the weakness because these are what you can do for rotator cuff. They're going to be normal. And we published me and Bertelli about it. You can read about the article about like specifically how you do exam for the deltoid. Now you can have perfect deltoid, perfect brachial plexus, but you have a massive rotator cuff tear. Now you have pseudoparalysis or pseudoparesis. So we saw different scenarios where the brachial plexus could be perfect, but because the scapula was unstable or the rotator cuff did not exist, then you're going to have very limited range of motion. And this is why, with having normal joint, with the fact that shoulder girdle is 3 joints and 1 articulation, it makes it complex to try to restore the motion. So understanding these basics are very important to try to restore the function in patients with brachial plexus. The right and left, the left side, complete brachial plexus patient. On the right side, massive rotator cuff tear with some deltoid deficiency. So this is like our topic, of course, brachial plexus and how we're going to try to target the reconstruction. Of course, the most important, like anything else, we need to see what's absent, what's available, what we can use. And in short, like the muscle that's usually available, except if a nerve transfer was performed, like spinal accessory nerve transfer, is the trapezius. And the trapezius has the upper middle trapezius and lower trapezius. So we can use the upper middle trapezius for stabilization and abduction, lower trapezius for shoulder external rotation. Muscles that are preserved in general, even in complete brachial plexus, the majority of the time also include levator scapulae. You can use it for scapular stabilization. And also the upper part of the serratus is available as well for subscap. Now, for deltoid, if the latissimus is available, it can be used as a flip muscle for deltoid reconstruction and the pectoralis major as well for flip reconstruction. And this is like a very quickly, like an overview about what could be done. And now the question is, having all this option, here's the question. Shall we try to use everything we have to reconstruct every rotator cuff and every deltoid, like all the deltoid? And the answer is no, because when we start to do these kind of reconstructions, this is a paper we published, I think, in 2012 at the Mayo Clinic, where we did these multiple transfers, including levator scapulae, upper serratus, lower and upper aspect of the trapezius. And what we found that from all these transfers, whether we do all of them or part of them, we're able to stabilize the inferior stabilization, subluxation of the shoulder and mostly improve shoulder external rotation. So adding muscle for the transfer did not necessarily improve the function. So we start to change this mentality over time. So what are the more optimal tendon transfer options to restore shoulder function? One by one, lower trapezius was the most reliable. And this is why in some of these talks that you heard, some of the surgeons now, they're trying to preserve the lower trapezius if possible, if there are other options, because we can transfer it for the infraspinatus to improve shoulder external rotation. And this is the first lower trapezius we did in 2007. We augmented with tendon allograft. But then we realized over time that lower trapezius in the setting of brachial plexus could be done direct transfer. Why? Because in brachial plexus, more than 90-95% rotator cuff are intact. So you can do a direct transfer of the lower trapezius to the infraspinatus tendon, which is the strongest kind of construct because the bone in brachial plexus is very soft. So it will be a better kind of reconstruction. And we did a lot of these cases overseas. Honestly, we've done over the past, I don't know, 18 years, at least 1,000, but a lot of them overseas and a lot of them here as well. And regardless of the size of the patient, when it is done appropriately with the right immobilization and the right patient, we can definitely improve or restore shoulder external rotation. Now, for patients who have additional, like if we want more than external rotation, and I showed you the different options, we don't have to do every single transfer, but we came up with what we call the 3-muscle transfer. And the 3-muscle transfer is essentially using the upper trapezius, the upper and middle trapezius as one transfer, lower trapezius another transfer, and then we use a levator scapulae at the third. So if I'm moving the whole trapezius, I need something to stabilize the scapula. So I use the levator scapula for the scapula. So we use the lower trap for infraspinatus for ER, upper and middle trap with the bony insertion for the proximal humerus for stabilization. If you notice, I did not even say abduction because it doesn't give much abduction, it's mostly stabilization, and levator scapulae to stabilize the scapula. We call it 3-muscle transfer. And this is like a few seconds showing the technique, essentially taking upper middle trapezius, lower trapezius, and this is elevator scapulae, all of them with piece of bone except for lower trap. And then we transfer the elevator scapulae to stabilize the scapula, upper middle trapezius for humerus stabilization, and lower trapezius, as you see it here, for stabilization and external rotation. So this is what we call the 3-muscle transfer, and it is really effective in stabilizing the inferior subluxation of the shoulder and to give shoulder external rotation. And this is a patient who had completely flail, I showed you, and she was able to get external rotation and what we call a functional shoulder. Another patient, like we have a lot of examples of such patients. And this is a patient who had like weak elbows. We used the Mayo Elbow Pro, and then we added these 3 muscle transfers, and she was able to get a good shoulder external rotation, and at least it will become a functional arm. Now, if the ipsilateral trapeze is not available, we can use a contralateral trapezius augmented with lumbar fascia to the ipsilateral side. So essentially, you can transfer it either ipsilaterally, or as Bertelli talk about, ipsilateral to the triceps or contralateral to the shoulder external rotation. So, and for the sake of time, I don't have much time here. So you can see you harvest through a double incision, the lower trap, and then you bring it from the proximal incision and transfer it to the contralateral shoulder and attach it directly on the shoulder. We have a lot of length in it. And we can definitely, and this is not difficult at all to train. This is an example, another example. And this is, in fact, Brian Loeffler sent me this one. I know you know him very well. He sent me a patient of his that he did for him contralateral trapezius. You know, was happy to was able to get him at least 20 degrees of external rotation. So can we be optimistic about getting the deltoid again in a couple of minutes? Yes, but we're gonna use either pedicle pect or pedicle lat. And these are a lot of cases we see more routinely when we have deltoid and rotator cuff injured from different type of surgery and pathologies. The majority of them now, I see them in my practice for reverse shoulder arthroplasty. So the pedicle pect is the way to go. It has 3 parts. There are 5 ways to do it. The most important is the upper 2/3 of the pec. We flip it as a flap to reconstruct the anterior deltoid. And again, for the sake of time, so usually we separate the clavicular from the sternal head, and then we're gonna take only, we're gonna leave the lower third of the sternal head and just take the upper 2/3, and we detach the origin, and we keep it on its pedicle. And this is live surgery. In fact, I did it in anesthesia for a patient, and then we flip it on its pedicle 180 degrees to change the angle from being an adductor to a flexor. So, and we use a lot of suturing at the clavicle, like with endo buttons to attach the muscle to it. And you can see the line of pull change from horizontal to vertical. And like this is a patient had no shoulder. We can get them, almost the majority of them, around 80 degrees. This is the other patient has complete deltoid dehiscence. We did him in Bulgrist, and also he had very good function. So like the majority of the patient get this kind of function, not all of them, but they get around 80 to 90 degree of flexion. Okay. So I'm going to stop here. I was going to talk a little bit about fusion, but I'm going to stop here. I felt like I'm running because of the sake of time. We're way behind, but thank you very much. Thank you.
Yeah, that's so great, Bassem. Thank you. Really a pioneer in this, and obviously your work is kind of leading how we, treat these injuries, which is amazing. Well, I appreciate everybody's time over a little bit. We'll have Teresa finish us off with the rehab approaches as well as the psychosocial aspects of treating these patients. So Teresa, please take it away.
Sorry. Good evening. Hope everybody can hear me. My name is Teresa Hallinan. I am an occupational therapist and certified hand therapist at the Duke University Health System. I get to work with wonderful surgeons like Dr. Neil Lee, or Dr. Warren Hammer, and Dr. Suhail Matani. So I appreciate the opportunity to talk about this. So sorry, I have 2 screens open. So for this story, I'd like to start somewhere in the middle. Here. The The middle of a busy, sometimes chaotic, but overall happy life. Here we meet Alex, a 38-year-old man with his wife, Marissa, their 2 children, Amara and Micah. Alex is a helicopter mechanic in the Army who is stationed in Fayetteville, North Carolina. He enjoys coaching youth soccer, spending time with his family, and playing guitar and riding a motorcycle. So, unfortunately, as many of these stories go, Alex was hit by a drunk driver while riding his motorcycle. He was unconscious when EMTs arrived, and he was life flighted to the nearest trauma center in serious condition. When at the hospital, he was found to have a right hip fracture, left distal radius fracture, suspected right brachial plexus injury, and mild traumatic brain injury. Alex underwent several hours of orthopedic trauma surgery. The road to recovery after this accident was not easy for Alex. He stayed in the hospital for 10 days prior to being discharged to a rehabilitation hospital for 2 weeks, where he received additional occupational therapy and physical therapy before transitioning home with his family. Despite being home with his family, Alex has significant neuropathic pain in his right arm. This is in addition to the orthopedic pain in his hip and left wrist. And during his first 2 appointments with the occupational therapist, Alex talks about worsening headaches, feeling sad, angry, as well as memory and inattention issues. He finds sleep difficult due to pain, in particular the burning pain in his right hand. He is not able to drive at this time. And during subsequent sessions with his therapist, Alex said that he did not feel like himself and was spending most of his days alone instead of with his family. He's dependent on his family for most things. His wife helps him get dressed, shave, put on deodorant, prepare food, and does all of the caring for their kids in their house. So, survivorship after traumatic brachial plexus injury can be considered a distinctly but important part of the patient experience, one that we as providers cannot forget. So, based on a recent examination of the literature by myself for this presentation, we can think of these themes as part of the puzzle in care folks following this injury. In the center, we have Alex again with noted challenges beyond his physical impairments. So let's take a closer look at what patients with traumatic brachial plexus injury truly face, beyond the surgery and the diagnosis. Psychological distress is often the first wave. One patient put it simply, "I went to work one day and then it all changed." The emotional toll is heavy: depression, anxiety, anger, and grief. I personally have had patients tell me that they have had suicidal ideations without plans. And as a therapist, we get to work with these patients a lot more intimately than our surgeon partners. And so they do tend to disclose a lot of really sad and sometimes upsetting elements of what they're dealing with after this injury. So getting back to this more recent research here, the emotional toll is heavy. Depression, anxiety, anger, and grief are common companions in this journey. Some, like in Miller and Dee's article, describe it as being a patient for the rest of my life. Then there's a loss of identity. As Brito and colleagues reported, many patients feel the need to create a new identity. They are redefining their roles at work, in their families, in their communities as they search for what is new normal. Additionally, there's a huge financial burden. And another, Kay and colleagues found that nearly 1/3 of insured patients in the United States met the threshold for catastrophic health expenditure. This means that it's not just medical bills, it's lost wages, lost opportunities, and limited pathways back to work. And then when it comes to rehabilitation, access is uneven and sometimes inadequate. As one patient shared, it felt like a fight on your own. According to Evertson and al., access to knowledgeable person-centered therapists is limited, and care is frequently disorganized, delayed, and inconsistent, leaving patients without a clear path forward. And these aren't isolated issues or persistent themes that echo across the lived experience of those with traumatic brachial plexus injuries. So let's turn our attention to see what actually helps support healing beyond some of the clinical intervention. First, coping. In one article, they found that acceptance and emotional support were among the most common and effective strategies used by patients. Those who developed active intentional coping mechanisms experienced significantly lower levels of depression. And I can tell you that the patients that are severely depressed tend to be less engaged in the therapy process. And so it is important that as therapists and physician partners that we all are identifying when someone is struggling. This tells us something powerful. How we help patients cope matters just as much as what we do surgically or physically. Next is patient-centered education. Navarro and colleagues developed, and this was along with Dr. D out of WashU, developed the Journey Guide, a tool that patients described as filling the critical gap in brachial plexus injury education. Unfortunately, not all patients or caregivers have access to this level of clarity. Health literacy remains a huge barrier, and many families struggle to understand what's happening or what comes next. We need more tools like the Journey Guide, ones that speak the patient's language and illuminate their path forward. And finally, we must address the weight of social isolation. I personally worked with a support group here at the Duke University Health System. And some of the things that patients would say are like, I wish I knew someone with this, or parents might say, I wish I knew other parents going through this. These aren't just comments, they're calls for connection. So let's check back in with Alex. He's now 4 months after his motorcycle accident. And since his injury, his life has become a full-time job of medical care. He's had appointments with an orthopedic upper extremity nerve specialist, hey, Dr. Lee, neurosurgery, orthopedic trauma, neurology, and physiatry, each visit layered on top of the last, each one bringing new information and new decisions. Alex spends his week cycling through tests, evaluations, and therapies. He tells us that he feels his entire identity has shifted from who he was to who he is now as a patient. Now, there is some progress. He no longer needs a device to walk, and he can now do about half of his self-care using his non-dominant hand. But he still needs help, especially for grooming. And he continues to wear a sling for pain management and to prevent kind of stretching of the plexus. Cognitively, there's some improvement. His memory is slightly improved, but he still struggles daily with inattention, irritability, and depression. At his last appointment with the orthopedic surgeon, Alex was told he would likely need surgery, and this would be the first of multiple for reanimation of his arm. He tells his occupational therapist that he's worried about these surgeries and how long the road will be ahead. And he says, I just hope I can get some use out of my arm again. This mix of fear and hope is something many patients live with, and sometimes something we as providers must hold with compassion, clarity, and partnership as they navigate forward. Finally, 7 months after his injury, Alex has a spinal accessory to suprascapular nerve transfer, neuroma resection, and sural nerve grafting. Rehabilitation specific to nerve transfer will begin in 2 weeks. So in my literature review, I found that therapists are also talking about what makes treating brachial plexus injury challenging. And for the sake of time, I'm not going to go into super great detail, but I've highlighted a few things here about training is limited, how managing psychosocial and neuropathic pain is a challenge, and developing therapeutic alliance. Access to rehabilitation approaches that offer some consistency, such as a donor activation focused rehabilitation approach, is critical. So peeling back the layers, I personally use the DAFRA approach. This was developed by Lorna Kahn and from Washington University in St. Louis and Dr. Amy Moore in 2016. It's really the only protocol or guideline for therapy to follow. And one of the first phases is donor activation. So for Alex's case, we have spinal accessory to suprascapular nerve. So the exercise would include some sort of trapezius activation. And according to Kahn and Moore's article, dosage of donor activation is about 10 to 20 repetitions every hour. And then in this next slide, I have a little bit more information on each of these phases, how they're progressed based on the manual muscle testing, with some samples therapy interventions. So I've begun using this analogy to help patients and their caregivers understand how donor activation, which is seen here in the watering can help grow nerve seeds into recipient tissues. The tree analogy helps patients understand that this is a slow process of arborization and that we will not see changes right away. So going on to, again, for the sake of time, because we have about a minute or so, here are some of my personal interventions that I add for folks after any nerve transfer, both pre-op and post-op. I just want to highlight a couple of things here that I found that adding conditioning exercises, including walking on a treadmill, using the new step or arm bike, is an important component of rehabilitation to encourage greater overall health and well-being. Never forgetting that the posterior chain, core, and scapular stabilization are critical to the rehab program, as a lot of scapular dyskinesia and core help to facilitate reaching patterns. And finally, dosage parameters following nerve transfer surgery is limited. We really just don't know what is the just right amount of exercise and activity in the context of nerve injury. An important component is educating the patient and their family on not working to fatigue. If the recipient muscle feels tired or the quality of movement or the exercise is diminished, it is likely time to stop the exercise. Axonal regeneration is slowed if pushed to fatigue. More research is needed to better understand this phenomena. So at Duke, we have a care paradigm shift. So we've developed the nerve health program, which addresses the gaps that we talked about earlier in the literature, and it provides a client-centered and holistic pathway to improve health outcomes. It leverages rehab professionals, including OTs and PTs, to create continuity, care coordination, systematic collecting of objective data, as well as patient-reported outcomes, and ongoing systematic check-ins. Additionally, this program offers physician partners the ability to directly refer to the program to primary nerve health providers, which are the OTs, PTs, that are trained on concepts of nerve health and help facilitate care pathways. They have dedicated clinic time to focus on these interventions for patients enrolled in the program, including both in-person and distance health visits. And patient enrollment and engagement is ongoing. This creates a support network for patients, families, and caregivers, and prevents a lot of loss of patients to follow up. And this program is based off of a program that's already here at Duke, the Joint Health Program, which has shown significant positive outcomes for folks with osteoarthritis of the hip, knee, shoulder, and thumb. And we suspect that our the Nerve Health Program will produce similar results. So in closing, while we often step into a patient's life somewhere in the middle of their story, we must never lose sight that this truth. It is not the end of their story. The path of survivorship after traumatic brachial plexus injury is rarely linear. It's a winding, uncertain, and deeply personal. Each turn, each obstacle can profoundly alter the course of the recovery and the identity of that patient. Alex's story is one example, one lens through which we can reflect on how to better serve, support, and uplift those who we care for. Though Alex is a fictional patient, his experience is drawn from the voices, struggles, and resilience of many real patients I've had the honor of partnering with. Their stories compel us to do better and remind us that behind every nerve injury is a whole person still writing their next chapter. This is my contact information. If you have any questions or would like more information on rehabilitation specific interventions following nerve transfer or tendon transfer surgery, please don't hesitate to reach out. And thank you for letting me share my rehab experiences.
Amazing. Well, thank you, Teresa, and all the speakers that have joined us tonight. Sorry for running over, but I hope that was helpful for everybody who's stayed on thus far. Thank you. Suhail?
Yeah, thank you, Neil, for putting this together and for all of our speakers. I mean, it was really a far-reaching, broad program and really kind of cutting-edge, insightful work. And so, unfortunately, with the amazing content that we had, we've kind of come to the edge of our time limit and maybe crossed past it a little bit. So I'll probably, rather than having a Q&A, we'll probably leave you all to the rest of your evening and really appreciate both of the society's engagement for making this possible and the attendees for really kind of coming in and participating. And the number of folks, despite the fact that we were going on, the number of folks on the Zoom really didn't waver the whole time. And that's probably a testament to the quality of the content and the engagement that the speakers have provided. So thank you all so much for coming this evening. I'll turn it over to Warren for one last word and we'll go from there.
Yeah, thank you, Suhail. I echo, I'd like to thank everybody for participating tonight. There were some outstanding presentations. I thank the audience and thank ASPN for being our co-host for this. These will be recorded and available at the AAHS website, and please check out our future webinars at handsurgery.org. Thank you very much, and everybody have a great evening.
Good night, everyone.
Thank you.